Hello, everybody. Welcome to another Phia Group webinar brought to you by the Phia Group Empowering Plans. I got to tell you, I'm really excited about today's topic. So thank you for joining us. Hopefully you're as excited as I am as well, and that's why you're tuned in and not because you've got nothing better to do on a Thursday afternoon. I don't know about you guys, but I am still feeling the after effects of this time change, losing an hour. It's funny because up until a few days ago, my 3-year-old son, he would wake up at 6:30. He'd be bright-eyed and bushy-tailed, and he'd look at me all tired and say, what's wrong with you? And I think, to be young again. But I got to tell you, the last few days, I've been waking him up, and he's giving me this look like he turned into a teenager overnight, and he doesn't want to get out of bed. So if you feel like I do, you may be rubbing your eyes and trying to get ready for this webinar, but I'm hoping that today's topic will excite you as much as it has us, and as a result, you're going to wake up for it. We're talking about transparency. Now, I'm going to assume, and again, I don't have the list in front of me of everybody who's logged in, but I'm going to assume that about a third of you are senators and representatives from Congress, and you're listening in because if what I've been reading on the internet is true, and the internet never lies, right now our government is obsessed with transparency. And of course, they've all got the Phia Group's emails coming to them, and when they saw that this was today's topic, they couldn't help themselves but dial in. So I'm pretty sure right now there may or may not be a government shutdown, but it's only going to last the hour that this webinar takes to get through it. If you are not a representative from our government, then you're one of the exceptions here, so you're amongst fine company. Take my word for it. It's not like you can actually see who else is logged in. So without further ado, let's go ahead and proceed. And oh my goodness, what is that? So I'm going to say that there are two obvious things right now. One is that Adam is not with us today. He is on the road representing the company and our allies in the industry. So thank you for the work you do, you road warrior, Adam. And the second thing is, I think I lost that tie. That's what my eyes are going to. I love that tie, and I realize I don't know where it is. And with me, Ron Peck, your senior VP, actually executive vice president. You can congratulate me later. Jen McCormick, she stole the senior from me. Brady Bizzaro and John Jablon. Brady, honestly, you've never looked better.
Thanks, Ron.
You are so excited to talk about transparency today.
And by the way, that tie is awful, Ron, so we burned it for you.
Oh, is that what happened?
Yeah.
All right, I'll accept it. Much like the New York Giants fans in their Odell Beckham jerseys. Anyway, moving on. So LinkedIn, before we get into transparency, I want to actually promote some transparency and tell you, yeah, I'm talking specifically to you. No, don't look over there. I'm talking to you. We actually just posted something specifically about you on LinkedIn. Now, if you're already following us on LinkedIn, then you already know that. But if you're not following us on LinkedIn, you have no idea what we just said about you. So here's my suggestion. Log in, find the Phia Group, follow us on LinkedIn, and this way you don't have to worry about whether I'm telling the truth or not because you'll already know. And frankly, if we do say something about you and you don't quite agree with it, I'm all about transparency here. Be sure to tell us what we missed, and we'll potentially consider a potential maybe correction.
How very definite.
That was very lawyerly of me. So speaking of social media and opportunities to hear about what's going on, you may have noticed that our webinars have gotten progressively more lively and much less candid. Frankly, I think that with our podcasts, which you can subscribe on iTunes, I think Podomatic, some other services. Go to our media site on our website, and you can discover all the different ways to follow us, our podcast. Our podcasts, we can literally say anything we want, and then afterward, we edit. And if you only knew how much content we edit out. But the problem is these webinars are live, and I'm like a trained animal at this point where I'm so accustomed to somebody editing the audio that I forget we can't edit these webinars. So listening into these webinars, do so at your own risk. But if you want something a little bit more polished and a little less salty, be sure to dial in and subscribe to the podcast as well. I promise you won't regret it. In case you are still tired from daylight savings, that'll be the final push over the edge and help you fall asleep. So speaking of people that will help you fall asleep, I'm just kidding, Dan. So a special shout out to Dan DaCosta, from Risk Strategies. He is a fan. He emailed us to let us know that he's listening in. And as we do every month, the randomly selected listener of the month will receive a swag bag. So keep your eyes on the mail. If it doesn't show up, it's possible that your local postal carrier confiscated the bag and kept it for themselves. So if you do notice someone delivering the mail and a wicked awesome Phia Group t-shirt, you know what happened. So, speaking of shout-outs, as you know, we've been making a concerted effort to identify and introduce people to what we call faces of Phia. These are Phia employees, Phia team members who do a lot for the company, do a lot for our clients, but because of the nature of their work, they don't have a lot of face time with the clients, with the outside world. In other words, they're locked in a closet right now working on your behalf. And so, because we're so kind, we wanted them to get their 15 minutes of fame. And so, you see before you our most recently named faces of Phia, Lunica, Tomash, and Zachariah, or as we call them, Zachy John. These guys, honestly, I'm looking at these pictures. They look like the villains from a John Wick movie. Am I right? I mean, first of all, they are all so fit. They all have such serious looks. Each one looks like they could kill me with a pencil.
Well, Tomas is European, which is why he looks so
He's got that added element, but all three of them. But I got to tell you, instead of taking out the bad guys, they're taking out the high claims and helping you by saving the day and saving some money for your plans as well. So again, get to know them. And I mentioned already our podcast. We're very pleased to do our Faces of Phia podcast. If you're subscribed to the podcast, you'll get those as well, where we actually interview these people and talk a little bit about what they do, what drives them, and why they're so happy to be here with the company. So, it's really worth it, and these are great people, and we're very happy to introduce them to you. So, what are we going to be talking about today? Well, amongst other things, we'll go ahead and talk a little bit about what drives people. I just mentioned those three faces of Phia, but our purpose, which ultimately trickles down to why we're talking about transparency today and why we cover all the topics we cover on a monthly basis. And then from there, we'll talk a little bit about some of the hot topics that our consulting team has dealt with. From there, we'll talk a little bit about what's going on Capitol Hill. And then we jump into the topic of the day, transparency. So I'm very excited to do that with you today. Keep your hands inside the ride at all times, and we'll get through this together. So why are we even talking about transparency? Why do those faces of Phia employees care about what they do? Why do I sound so upbeat to be sitting here and talking to you about this today? And it's because we see the ultimate effect of what we do. If you focus just on the minutia and what you're dealing with on a case-by-case basis, it's easy to forget what your ultimate purpose is. What are you trying to do? But if you look at sort of the downstream effect of what we and what you are doing and why you're listening and we're talking today, we're ultimately trying to maximize health benefits and minimize costs, which is going to benefit our friends, our families, fellow American workers who are, by and large, still receiving their health benefits through their employer and through their employee benefit plans. And if we don't take active steps now to preserve it and preserve those rights, another option is going to pop up. And for those of us in the industry, forget those who say, well, I'm just trying to save my job. Even if you told me that I was going to get a big payout and I could retire tomorrow, I'm still concerned that those alternatives are not going to deliver. And you look at other examples in other countries where it's not working the way they hoped it would, and I worry. And I worry that we have that grass is greener attitude in general amongst the public, and I'm concerned that people are going to get what they wish for. And if we don't do something now to truly get people to appreciate what they currently have, then they're going to reach for that alternative that ultimately may be far worse. So we have an obligation in this industry to take action now, to take something that's good and make it even better So it's a no-brainer and it's not abandoned. And that's ultimately why we're going to talk about transparency today. But before we do so, let's first talk about some of the hot topics that our consulting team with which they've been dealing. And nobody knows more about the pressing issues than one Jennifer McCormick. So Jen, take it away.
All right, very good. Okay, let's get started here. So question number one, what do we need to know about the coverage of transgender-related benefits? So this question has been coming up in the context of questions about Section 1557. So there has been a lot of confusion about what this means for a plan, what this means for an employer. So let's get down to what exactly you need to know. So in general, the rule under 1557 is that a plan or entity who otherwise is subject to the rule is prohibited from discriminating against individuals on certain classifications. One of those classifications is sex, and within that category includes gender identity. So as part of that, the regulations under 1557 say that an entity subject to this rule is prohibited from having a categorical exclusion on certain transgender-related benefits. So as a quick reminder, there's generally three types of categories where these types of benefits might be seen. First, under the prescription section, there might be certain hormones or drugs that are required for coverage. Under the mental health, maybe there's counseling that might be required as part of the transition. And then under the surgical benefits, there might be certain surgical procedures that are going to be required as far as that benefit is concerned. So what we still don't know is whether or not a categorical exclusion would still be applicable, or would mean if the plan made the decision to only cover the surgery piece and to exclude the counseling or to exclude the prescription or vice versa. So that's a little bit unclear, but just know that the rule under 1557 is that there's no categorical exclusion. So what that means to you and how those three categories are going to be balanced on your plan design are going to be up for interpretation, at least until we get further guidance. With all of the unrest that's going on right now politically, I'm not sure how soon we'll get that clarification. The other thing to be concerned about 1557 is that in general, if you're receiving any sort of funding from HHS, then generally you're going to be subject to this rule. So if you're getting a grant for a study or from some other type of program that you're offering, if you're a hospital, if you're a physician group, those are the types of entities that are going to be subject to these regulations and rules. Next, how is preventive care related to HSAs? So in general, this has come up in the context of other types of programs or cost containment incentives that are being added to plans. So an employer found this really great opportunity to increase the value for their employees and also save money at the same time. But they realized that they have a high deductible health plan. And with a high deductible health plan, we know that the rules in order to retain that status as a qualified high deductible health plan is that you can't offer first dollar coverage unless it's for preventive care. So the concern here is how are we going to fit these things together so we're not violating these rules, specifically trying to not eliminate our ability to retain that HSA. So the only way that you're going to be able to have these work in collaboration together is if you are covering, the only things that you're covering at 100% or first dollar coverage are going to be those preventive services. So there's going to need to be a way that you're going to have to figure out what the cost or the value of the services would be if you're trying to add some of those programs or other incentives into the plan where the deductible is still going to need to be met. And last but not least, what do we need to know about dependent exclusions? So much to know here. But the main thing to remember is when it comes to dependent exclusions, there's generally two different types of categories when we're talking about dependents. We're talking about children or grandchildren, and we're talking about spouses. So under the first category, children, we know that under ACA, that there are requirements to comply with the employer mandate that you have to cover your dependent children through the age of 26 to the end of the month, of the calendar month in which they turn 26. So any type of exclusion that would exclude a child who still falls within those eligibility criteria is going to put you at risk for an employer mandate penalty. But good news for the second category, the spouses category. So under that category, there's no ERISA rule, there's no ACA rule that's going to require a plan to offer the category of spousal coverage for the plan or underneath the plan. So there is an opportunity there to have an exclusion, to maybe categorically exclude all spouses or maybe to have an exclusion that is carved out for maybe employees who have spouses that have coverage under their own plans, or maybe that you would offer a surcharge, there'd be a surcharge requirement for those types of other plans that might be available if that spouses have that coverage. But the key thing here to keep in mind is that when you're putting these types of exclusions or caveats or conditions in place, particularly for spousal coverage, you're going to need to make sure that this is going to be something that you can and do have the ability to administer, that there's not going to be a difference between based on which spouse is covered or not covered, and also making sure that everything is being clearly communicated with all the other entities. So whether it's the stop loss carrier, anyone else who's involved in the process, just make sure there is transparency. And with that, I will turn it over to Brady.
Thanks, Jen. And yeah, in keeping with the buzzword of the day, transparency, I thought there was no better place to start than talking about some of the fallout and things we learned from a hearing that happened on Capitol Hill a couple weeks ago involving 7 of the top drug makers in the country. So all the companies there that you would expect were there: Pfizer, Merck, Johnson & Johnson. It was a 4-hour hearing that you didn't watch, so I watched for you. And what I want to do is just break down a little bit about what happened there, the takeaways, some important factoids that were revealed. First thing to note here is that this was a hearing in which both Republicans and Democrats asked tough questions. They're serious about getting a hold on drug pricing. It's been a focus of the administration now for a couple of years, and I think we learned some interesting things. First is the CEOs are sort of asked a number of questions where the senators wanted a yes or no answer, and one of them I found interesting was they asked whether they consider negative public opinion when they're setting their drug list prices, and they all said yes, which is important because it means that when they're setting drug prices, they don't just rely on administrative costs or R&D costs. They rely on public perception. So implicitly, if no one would get upset, they would raise drug prices. That was interesting to learn when they had that discussion. They also talked a lot about insulin, which is one drug in particular that's gotten a lot of focus in the news because it was invented in 1920, and yet the price is doubled in the last 4 to 5 years. Inexplicably. In fact, they had a woman at a hearing in the House a couple weeks before that whose daughter had died because she was rationing her insulin use because it became unaffordable. So it was a really serious discussion that they had. And what I did was I broke this down into 5 takeaways about what I learned from this hearing, I think that are important for our industry. So the first one here is that the manufacturers all seem to support the administration's proposed rebate reform rule. You'll recall that we've covered this previously in a podcast and a few blog posts that the administration released a blueprint for tackling drug prices. And one of those proposals was the elimination of knowledge that, hey, rebates aren't actually causing list prices to fall. In many cases, they're leading to increases in list prices. And so what the administration proposed was a rule that would ban rebates for Medicare Part D only, which is huge because Medicare is the largest purchaser of drugs in the country. And so the thinking there, as senators begin developing bills on this topic, is that it might bleed over into the commercial sector, into private insurance. And we could see PBM rebates banned altogether outright. And in fact, when senators asked the CEOs about this issue, 2 of them told the committee that they would actually lower their list prices if the rebate ban was extended to the private market. That's important. So we'll watch and see how these bills take shape. But the focus is definitely on rebates and also the drug discount copay cards as a source of actually exacerbating the problem of unaffordable drug prices. Number 2, PBMs remain at the center here of this discussion. You had a lot of finger pointing by the CEOs. They're saying, well, blame PBMs. They're not negotiating enough. They're not getting good enough deals for their clients. Don't look at us. And in fact, PBMs will be dragged before the committee in the coming weeks to explain themselves as well. But the senators are aware that, or rather they're unaware of exactly how PBMs work. And frankly, in our own industry, a lot of the inner workings of PBM world are unknown. So I think we'll see more sunlight on this issue, on this area, and we'll wait and see how that plays out. Number 3 here, Americans pay a disproportionate share of R&D costs. This, I think, is probably obvious, but it was pretty interesting to hear these people admit that we pay the highest list prices for drugs in the world, and we have the highest share of our tax dollars go toward R&D, and yet the CEOs always use R&D costs as a justification for their high list prices. And they also admit that they still make a profit on foreign drugs. So why is it that Americans are shouldering the burden, the largest burden of R&D costs? They didn't have a good answer for that, but they acknowledge that, maybe it's a bit unfair to us that we're paying for everyone else to, enjoy the results of R&D. Number 4 here is the possibility of value-based arrangements was discussed, and it could play a larger role to address the problem here. So the idea here is that with value-based purchasing arrangements, sometimes called risk-sharing agreements, it would tie the drug payments to patient outcomes. So if a certain drug failed to produce a particular outcome, a clinical outcome or financial outcome, that the manufacturer would reduce the price or a refund would be triggered. So these arrangements would be entered into with a PBM and the manufacturer, and then with a PBM and the plan sponsor eventually. And this could lead to sort of more precision medicine and would result hopefully in more targeted treatment for people with chronic conditions who are on specialty drugs, for example. But it's complicated to get these arrangements in place because of things like anti-kickback laws and, of course, these proposed rebate reform rules. If you eliminate rebates, then you can't use them as a way to focus on these value-based arrangements. But I think it was worth discussing that this could be in the future. And finally here, they all agree, surprisingly, that, look, status quo is not working. They acknowledge our prices are too high. We can't keep going this way. And in fact, some of the CEOs actually called for government intervention, which is pretty shocking. But nevertheless, that's what happened. And I think the hearing overall, a lot of these things are sort of parades, whether you have the tobacco industry hauled in front of Congress and, a lot of talk, not much action. In this case, though, we're going to see action. I keep saying it, but I promise you, we will see action. You've got proposed rules already. You've got senators working on bills. And you have a number of other developments that I want to get to in the short time we have that are important because they do relate to drugs and the FDA more broadly. And the first thing to note here is that something surprising happened a few weeks back when the FDA commissioner, Scott Gottlieb, unexpectedly resigned. He was what I would call a unicorn in this administration because he had close ties to the drug manufacturing industry, and there was suspicion that he wouldn't be a friend to self-funded plans, to health insurers in general, but actually he was a really staunch regulator. He did a lot of things that both sides of the aisle praised, and he was very effective. We now have an interim replacement, but we don't have a permanent FDA commissioner at the moment. Why should we care? Why is this a loss for us in our industry? 3 major areas that he worked on. Reducing the price of drugs was one of them. He actually worked to speed up the review process for generic drugs. And in fact, in 2018, an all-time high number of generic drugs were approved, 971. That's a lot. It grew by 24%. So you had more drugs getting to market, which was lowering the cost because they're generics. 2, he focused on the opioid epidemic, which is a big deal. 85,000 people have died since 2017 in this epidemic. And among people with inpatient episodes, the average inpatient cost to treat someone with opioid addiction totaled $16,000 in 2016. That's up from $5,000 in 2004. So it's costing a lot of money for fully insured plans, self-insured plans to deal with this crisis. And he took a hard stance on opioid prescription limits and approved a mobile app to help those with substance use disorder. It was a really good thing. And finally, cracking down on e-cigarettes, which if you haven't watched the news, you know that's exploding among teens and young adults in terms of usage. These e-cigarettes contain additives that can cause lung cancer and other diseases, which are expensive to treat. So cracking down on that was a good thing. We've lost him, and unfortunately, we'll see who replaces him, but he was doing good things and was a good ally, I think, in our industry.
Brady, was that intentional, referring to the usage as blowing up? Because I've also seen a few stories about them actually blowing up.
Maybe it might have been. I'll let you decide that.
I'll let you take credit for it. That was
all right. I need to confirm or deny that one. The second topic here, I'm going to share this with Jen, but another huge development in our industry that impacts our clients directly was this FDA warning letter that came out a few weeks ago regarding drug importation. And so it's a big deal. There's actually a letter here that you can read where the FDA has warned a vendor, a popular vendor, for their business model, which essentially involves them serving as a broker to set up employers, or rather members of employer-sponsored plans with brick-and-mortar pharmacies in Canada, in Great Britain, in Australia, to get them drugs from overseas. Now, this practice has gone on sort of unchallenged for almost a decade or perhaps more, and it's unclear why the FDA suddenly now decided to crack down, but it's a big deal because, basically they were issued a cease and desist order, and if they don't comply, who knows what's next. They could seize, materials, they could raid offices without further notice. But interestingly enough, Kaiser Health is reporting that still you have cities and local governments that are continuing to do this to import drugs from Canada, and they're going to do so, according to them, until they're told to stop. So we'll see how this plays out. But essentially what's going on here is the issue is causing misbranded and new drugs to enter into the stream of commerce. It's not necessarily about classifying these vendors as pharmacies themselves. No one's going on vendor websites and purchasing drugs directly from a vendor or from a pharmacy overseas, right? You have vendors serving as brokers, as middlemen. And the FDA letter is very particular, I think, and deliberate in noting that it's the action that these vendors taking to cause the introduction of these drugs into the stream of commerce that's a problem. And so it's a big deal, and our position, I think, is going to change or has changed as a result of this letter, because previously our position was that the FDA hasn't been enforcing this. Now they are enforcing it, and it's a big deal.
The only thing I'm going to add there is if there's any other questions or things, we'd be happy to talk in more depth about that and see how we might be able to help.
Yeah, sure. So feel free to reach out to us. We do have a lot more to say on that topic. It's very, very important and very recent. Finally, on this slide, and I know I'm short on time on this political update, but I want to note here that this 22 states are suing the administration over changes to Title 10. Basically, this is about federal funding for abortion, which is already illegal in most cases, but this rule would effectively remove Title 10 funding, which covers cancer screenings, contraceptive services, STD prevention, et cetera, from any entity which provides or refers patients for abortion. This could go into effect May 3rd, and this is very much related to the final rules that broaden the employer exceptions to the ACA contraceptive mandate, the inclusion of moral objections. Recall those rules have been blocked in 14 states by a federal judge in California. I think these two issues are very similar. They kind of go together with the administration's attempt to sort of erode protections enshrined in the ACA for contraceptive services. So we'll look and see how these play out, but it's very complicated. Reach out to us, and we'll give you our guidance on what to do if you're concerned about complying with the ACA in light of the recent developments here. And then I'll go through this one a little quickly too, because this is also a big deal here. But another massive case came out recently in mental health. It's been described as a landmark ruling. This is an area of health care, but it doesn't get covered as much as it deserves to, frankly. But basically what happened here is you had a federal judge who ruled on a case, really it was two cases that were class action lawsuits brought by United Behavioral Health members. United Behavioral Health is the largest mental health insurer in the country, and they had been accused of unreasonably denying coverage, mental health and behavioral health services to its members, including children, for residential and outpatient treatment from 2011 to 2017. The case essentially focused on United's treatment of acute conditions versus chronic conditions. The judge found that self-funded plans included in this case took or had financial motives when they were denying coverage for members who needed chronic care. So they presented with a condition that involved mental or behavioral health issues. And the plan was covering those acute conditions, those that could be treated quickly and efficiently, but they were denying more long-term coverage that was necessary in view of the clinicians. And the court found that the plan language was read to be arbitrary and capricious. It was applied in an arbitrary and capricious way and ordered a bunch of damages, including, by the way, fiduciary breach damages against United. So it's a big decision. We have a lot more to say about that one as well, but I thought it was worth bringing up now in this webinar, and reach out to us for more information on that. And finally, I'd be remiss if I didn't just quickly notice that Amazon has finally given a name to their joint venture with JP Morgan Chase and Berkshire Hathaway right here in Boston. It's called Haven. I'm sure there's a story behind that, but basically they're up and running now. They're hiring a bunch of people. I told Ron I'll be heading out the door in a couple of weeks to go there. Just kidding, but really they're really ramping up what they're doing, and they're focused on better access to primary care. I'm seeing here as I read, you should notice that these are all things that in our industry we're very supportive of and really relate to what we're doing, but focusing on primary care access, making insurance benefits more simple to understand and to obtain, and getting more affordable drugs for their employees. So they're doing a lot of what we're doing, and we're going to keep watching what they do.
Yeah, so Brady, I'm glad you brought Haven up. It's interesting because if you look here, and again, this is all kind of parsed out from the initial releases and their website. We've internally and also in presentations and on social media, we frequently indicate that we think healthcare is comprised of what we call the 3 Ps, right? So the patient, the provider, and the payer. And when you look at these statements that they're interested in working with clinicians and insurance companies, again, I don't necessarily see reference specifically to what they're going to have the patient, meaning their plan members or whomever, what they're going to do to try and reduce or control their own spending, which a lot of what we're going to talk about today with transparency ties to, is the actual patient. But when you talk about the clinicians and insurance companies, you're talking about 2 of the 3 Ps, the payer and the provider. So I'm happy to see that unlike some of the recent laws that have been passed that are almost entirely focused in on one or the other, they're taking that global view, which is great, and I appreciate that. When they talk about better primary care access, are we talking about primary care network maybe, which, again, I wonder if they're going to encounter some difficulties given that so many primary care physician offices are part of or owned by a hospital system.
Yep.
So to kind of separate the two is very difficult to do these days. Maybe this is an opportunity for direct primary care. Who knows, right? That's another thing. Simpler insurance benefits. Yes, definitely. One of the things that we preach here all the time is to cut back on the options and all the minutia and this high deductible this and that and simplify it so that you get better enrollment. People like a simple plan that works. So I definitely agree with that. The last thing I'll note, though, and you mentioned this, is that their primary goal, at least for now, is to figure out how to fix their own plan, right? A mere 1.2 million lives, give or take a couple, right? So the problem is that when you're talking about volume and steerage and clout, they actually have the power to accomplish things that if then they said, ta-da, we fixed healthcare, go ahead and, rinse and repeat. If you're an employer with, 200, 100, maybe 50 employees, you can't do what they did. Now, the only other thing I'll say is maybe with the proliferation of association health plans and the opportunities for a bunch of small plans maybe to gather together and become one large plan, maybe there's an opportunity there to emulate a little bit more closely what they've done. So I'm very curious to see the different approaches they'll take, and hopefully it's just another source of input on ways to try and improve things. So speaking of input on how to improve things, let's go ahead and talk a little bit about transparency for the second half here. When we talk about transparency, all right, if you look it up on social media, healthcare transparency, most people are probably talking about the cost of care, all right, the actual price of the medical care. And that's absolutely something upon which we will touch today. That being said, in our mind, that's only one of the transparency leaves on the tree of transparency, okay, one of the branches. We're not just talking about pricing, okay, we're talking about data, right? How many times do we have to tell you? Guys, February, Valentine's Day, we did. What do we love about self-funding, right? One of the things we talked about, or many of the things we talked about that we love for self-funding is access to data. That's another type of transparency, seeing what you're spending, on whom you're spending, what you're spending it on, right? Transparency in data, huge. Contracts, again, I can't stand the number of contracts and agreement in our industry that you sign, and it basically says, here are the terms, okay, I agree to them, and then the last line is basically, all of the terms in this contract no longer apply if it conflicts with some other contract that you're not allowed to see. What? So this is basically, I wasted all my time. If there's any conflict, some other contract I'm not allowed to review is going to control. That's a lack of transparency in contracting, fine print, things like that. It feels like so many things are proprietary, right? And again, it's a little sad that, and nobody is really excluded from this statement, that too many entities rely on a lack of transparency on this idea of things being proprietary to protect their business practices and profitability, instead of just offering a product that even if you pull back the sheets and say, there it is, it's still so well done and still so excellent and delivers on what it promises that even with transparency, it's still profitable. When you have to rely on secrecy in order to remain profitable, that to me is disconcerting. And that's just a personal feeling, and hopefully you agree. And I don't think we're the only ones who feel this way, because all of these entities that up until now have, I hate to say they've operated in the shadows, it's a little too dramatic, but they're starting to be called to task. And I joked before about Congress listening in on the webinar, but face it, you look online right now, and it seems like every day there's another panel of congressional hearing drilling and grilling some panel of providers or vendors or insurance industry, anyone, because they're just trying to get to the bottom of everything. So if we can't find a way to promote transparency in a positive way, and I said this before about replacing the industry in general, I think you're going to discover transparency is forced upon you. And you never want something forced upon you, because then you lack control on its rollout. So hopefully today we can talk about some ways that we could promote transparency voluntarily instead of having somebody knock on the door with an affidavit.
Thanks, Ron. Before I get into the health plan pricing transparency piece, I would actually like to quote a statement put out by the Trump administration when asking for TPA comments on price transparency. And I quote, "The fragmented and complex nature of pricing within the healthcare system has decreased the efficiency of the healthcare system and has had negative impacts on patients, healthcare providers, health systems, plans, plan sponsors, and other key healthcare stakeholders." And I continue quoting, "Patients and plan sponsors have trouble anticipating or planning for costs, are not sure how they can lower their costs, are not able to compare costs, and have no practical way to measure the quality of the care or coverage they receive relative to the price they pay."
Other than that, things are great.
Of course. But so, the bottom line is that whatever is going on with the government right now, it does seem that one of their primary focuses is transparency. And, when Ron just talked about transparency, he specifically mentioned that it's not only about provider pricing, it's about access to data, it's about health plans and stop loss. Basically, we're all in this together, and transparency is key no matter who you are. So with that, health plan pricing transparency. A lot of people think of transparency, and this is why Ron said what he said, but a lot of people think of transparency as we don't know what providers are going to bill before they do bill. That is certainly a huge part of transparency, but health plans themselves need to promote transparency because you're not going to get it unless you also give it. And in fact, the law requires that health plans be transparent, but so many health plans are trying to find ways around this for some reason. And one of those things is what we like to call here the black box approach to pricing. The idea of the black box is that a bill goes into the box, it shakes around, I don't know, maybe it stirs, and then out of the box on the other side pops a number. How did we come up with that number? I don't know. It came out of the black box. There are monkeys with calculators in that box. I don't know what they're doing. The plan's not clear on what they're doing. All we know is that we gave this to a vendor and they spit out a number. We don't ask why. We just pay that number. And when providers ask why, we say, well, that's the number we got from our vendor. That's not good. The plan should always understand what it's paying. And more than that, the plan has to, by law, be able to explain why it is paying what it's paying. So no matter what plan structure you're using, whether it's reference-based pricing, traditional PPO, whatever, if a provider is not able to understand and not given the information to understand the pricing, that's one of the main reasons that providers push back on pricing. When you're looking at reference-based pricing, it's funny because one of the main reasons that plans use reference-based pricing is to promote transparency and make sure that everybody knows what's going on using objective metrics. Well, there's no reason to use an objective metric if that objective metric is not very, very clear and correct. So if your pricing is unreliable, unclear, unexplainable, unexplained, all of that is very bad and it defeats the purpose of reference-based pricing. It's going to hurt you. You're going to get pushback. That's where appeals really start getting bad, when providers say, well, I get that I was paid this, but you haven't told me why. And when the plan responds to the appeal, they say, we paid you that because the plan document says it. Well, guess what? That's not enough. And a little bit later in a few slides, I'm going to get into what you actually have to say on EOBs and kind of how transparent you need to be. But just know that saying this is what our vendor told us, that's not enough. That's not good. And I think Ron's going to talk about that in a minute. But in any event, I'm telling you everything that we're going to talk about, but I should talk about what I am talking about. Strong plan language. If your plan language is descriptive about what the plan is paying, what it's doing, that is absolutely crucial for the law, for compliance, for general success of whatever program you're using. Clarity is key. And, we have been preaching that for years. And when we are able to help TPAs promote clarity in their plan documents, we love that. We go home happy. And when we're not, it's a sad day here at Phia. So one other thing to keep in mind is that I'm absolutely not saying that the plan administrator should not retain some discretion in the pricing. Discretion is great. I mean, we've been saying it for years. Discretion is absolutely key. The law has promoted discretion for a plan administrator. The problem is you can't have absolute discretion with no underlying rules. If the plan document says something like the plan administrator has the discretion to determine the plan's allowable amount based on whatever the plan administrator wants, that's not good enough. Yeah. The discretion has no rules. Discretion is useful for interpreting rules in the plan document, but statements like that, they're not rules. They're just for lack of a better word, they're arbitrary.
Right. You know, John, I actually like you're bringing up the word discretion, because
Right.
it's funny, because discretion as a term doesn't live on an island. It's discretion to interpret. And you can't interpret unless there's something there to interpret in the first place. So I think sometimes interpretation and the fact that there needs to be something to which you're going to interpret, that's lost. And that's a little sad to me. And, you know, it's funny because you talk about the black box and how it's not okay. Don't just take John's word for it. You know, this is established.
You can
right?
take my word for it.
Well, you could too, yeah. You know, it's a lot easier to just do that. But you'll remember even when Andrew Cuomo, this was back when he was Attorney General, so before he was governor, before he renamed the Tappan Zee Bridge after his dad. You remember the Ingenix lawsuit, where again you had a situation where you had payers, they were utilizing a price index, a vendor, to determine what's usual customary. And when they were basically asked by these providers, hey, I feel like I'm being underpaid, where did these numbers come from? Oh, well, we got it from our vendor. Okay, but how were they calculated? You know, can you reverse engineer where this price came from? No, we can't. Well, if you're the plan administrator and you can't explain or define where the number came from, that's trouble. And that ultimately was one of the main issues that led to this suit pursued by the Attorney General and a loss on the part of the plan. So, you know, being able to explain where the pricing came from and in detail and define it is issue number one. And then number two is, just because you can do that, that's not good enough. It also has to match the plan document. So it could be that instead of the Ingenix situation or the black box where I don't know how they came up with this number, instead it's, oh, I know exactly how they came up with this number. First we took Medicare, then we applied 50%, then we did a slight variation based on location, and then we did, and then you, oh yeah, look, oh wow, ooh, science, math. I can break down exactly where the number came from. But the plan document says that you're going to pay, you know, whatever the average that this provider normally charges. And it doesn't reference any of those things that you use to come up with your price. All of that transparency is worthless. So step one, be able to explain where the pricing comes from. Step two, make sure the plan document reflects that process. So let's talk about another form of transparency. And I've mentioned this before, but it still sticks in my craw because I don't think everybody completely understands, or even worse, don't necessarily agree with me, which is a cardinal sin. If you're talking about just sheer pricing transparency, where you're telling, hey, let's tell the patient what things cost and it'll solve everything, I disagree with that. And the reason I disagree with that is, in our industry, people may know what something costs, but if it's covered in full by their insurance, more or less, again, we can adjust for deductibles, copays, coinsurance, but more or less the price is covered by the plan. Why should they care how much it costs? To save the plan money? Yeah, I got people all the time knocking on the door. Hey, how can I give up something to make the plan better off? That's what everybody says. That's why we have a subrogation business here, because literally all you got to do is call people and they throw money at you, right? Yeah, sure. That does not happen. So again, you know, that's issue number one. Now, that as an aside, let's say there was no such thing as insurance. Let's say everyone's paying out of their own pocket. Let's say we're talking about over-the-counter medication for which there is no coverage. Even with skin in the game and the patient is the one paying, you look at these shelves and you've got the brand name and the store brand, and they're the exact same medication. No difference. The price is right there. Transparency. Hooray. Skin in the game. Yeehaw. And people are still buying the more expensive drug. So this is just proof that just knowing the price, even with skin in the game, is not enough. What's missing? And what I would say is missing is consumer awareness, understanding that the store brand is the same drug. It's equally as effective, that there is no difference. And we'll talk a little bit more about that psychological issue later on. But first, let's talk a little bit about some of the recent news and proposed rules regarding brand name drugs and out-of-pocket.
All right. So what if there was a rule that could help fix Ron's dilemma?
Oh, that would be nice.
Wouldn't it be nice?
Ron's got a lot of dilemmas.
I've got nothing else to talk about.
All right. So recently, well, as recent as late January 2019, HHS actually proposed some new regulations for pricing parameters and benefit parameters, among other things like setting forth what the 2020 requirements would be as far as self-only and family coverage, the really important and interesting thing that these regulations, proposed regulations actually outlined for us, were the opportunity for self-funded plans. Yes, are you paying attention? Self-funded plans to exempt or to exclude from the out-of-pocket maximum certain types of medications. So just like Ron was talking about, what if there was a way that a plan could exclude from the out-of-pocket maximum a drug, a brand name drug, if there was some sort of medically appropriate equivalent in the form of a generic that was available? Also, what if under the current regulations, or if they were changed, there would be the opportunity to exclude from the out-of-pocket maximum any of those drug manufacturer coupons for particular medications or drugs that also have a generic equivalent? So there are a couple of things about this. This could be a huge change as far as how we're going to calculate the maximum out-of-pocket, what is and is not included. It looks like we've been doing this for the past 9 years, and there's still confusion about what is and is not included. So this proposed rule, if actually becoming finalized, there still will be some administrative concerns as far as how we can administer it. But the one key thing that I got from this regulation was that this is actually telling us what the rule is right now, right? So there has been confusion out there about how we are supposed to treat these prescription drug or assistance type of programs. But isn't this regulation, by saying that this would not have to count towards the out-of-pocket, saying that it should be counting towards out-of-pocket now?
That's what I've been saying.
So by having this new regulation, maybe this is a really good time to take a look at how the plans are written and seeing how you're actually calculating or taking into consideration some of these prescriptions or these drug assistance, manufacturer assistance programs or coupons. So that's the other big thing. So the reason why they have put this, and I don't want to send any more quotes or quote any more Trump administration regulations as far as the rationale, but I did think that it was important that why they are putting this out there. Why are they proposing these regulations? What would be the impact of having these particular regulations in place? So a lot of argument has been that people are going to be, or physicians are going to be prescribing a lot of these brand name or more expensive drugs because of the coupon access. So what they're trying to do is to target that, to encourage the use of other lower medications, lower cost medications, so that it can be more beneficial for the plan, but also for the patient as well. There have been a lot of programs and a lot of problems for plans and for patients when trying to understand how these coupons and assistance will actually impact them. Right now, we are looking, last thing I'll say about this is that there's comments out. So comments were actually supposed to be submitted at the end of February. So I'm really interested to see what is going to happen as far as these comments. But some of the things that CMS was looking for in order to finalize this rule is they wanted to know whether or not states would have the ability to treat the coupons differently. So could Massachusetts handle this differently than Washington? They wanted to know how efficient, how effective it would be to actually carve out these coupons. Would that be something that an administrator or an insurance carrier would be able to handle? And whether or not you could differentiate between a prescription drug coupon that was for a brand name where there was a generic available or not. So all of these questions and the answers are still forthcoming, but in the meantime, take a look at your plans and see how you're treating this assistance currently.
Thanks, Jen. In the interest of time, I'm going to blow through this slide. As with everything we talk about, if you've got questions, feel free to email us at PGC Referral. PGC is Phia Group Consulting, so PGC Referral at PhiaGroup.com. With respect to EOBs, which I mentioned before, anytime the plan issues a denial, and a denial is not necessarily an entire denial, but any sort of partial denial, if one dime less than the billed charge, well, 1 penny really, less than billed charges is paid, an EOB has to be issued. And the EOB has to state, and the most important things are the G1, sub 1 and 2, the specific reason for the adverse benefit determination and the specific plan provisions on which the determination is based. The key word there, specific. The reason has to be, sufficiently descriptive as to really explain to the recipient or the claimant why the claim was paid as it is, and the specific plan provisions is kind of a hint to plans that your plan actually has to support what you've done, not only because the law says it does, but because you have to quote which provision allowed this denial. And with respect to notification of how the plan prices claims, of course the plan document is the primary piece that needs to say it. But you also need to make sure you talk to stop loss, but only if you want reimbursement. You should talk to providers. Outside of the plan doc, you might have to have other conversations, but only if you want to minimize the appeals. And lastly, talk to members. If you're instituting some sort of program that's different from what you've historically done or different from what the member might expect in any way, make sure you let the members know what's going on. And as I said, the plan document is the primary place to do that. But if anything is weird, if anything seems like the member might not understand fully what's in the plan document, have a conversation. Get HR to talk to patients. It's easy stuff. A lot of employers do it, and it's just, there's no PHI involved. It's just simple explanations of what the health plan actually says and actually pays. And actually part of that is fulfilling fiduciary duties of making sure the member knows what's in the plan.
So up until this point, I feel like we've been talking a lot about things that the plan and the employer and the broker need to do. And it seems like more or less the provider has skated by unscathed. And I don't want you to think that that's necessarily how we feel here. Certainly transparency from the provider perspective is important as well. If you look at the current state of things, more or less, you're not going to find out what things cost. Obviously, there have been legal action taken or regulatory action taken to post Changemasters, but you know as well as I that that's like seeing the sticker price on a car. That doesn't necessarily mean what they're accepting as payment, with much bigger spread than on a sticker price on a car, mind you. But, there is some price transparency, true transparency, not just, here's a sticker price, but we're not going to tell you what we really take. They actually say, this is what we will truly accept as payment in full. Surgery Center of Oklahoma, of course, being an example that's very much out there in the media. Free Market Medical Association, great organization, a lot of providers who are either doing this or considering doing this. What I think is interesting is when you see providers who proactively opted to be transparent with their pricing, they're publishing lower cost more often than not always, but more often than not than the competition. And they're not only publishing the rate, but the fact that they can offer this rate for the following reasons: quality, effectiveness, technology, whatever the reason. So it's not just about the price, but why the price is what it is. And I actually worry, and the reason I worry is because when you talk about price transparency, and I mentioned this before with the brand name drugs versus the generics on the shelf, is that if the day comes that the less effective, less efficient providers start to publish their prices the same way my friends over at Surgery Center and other providers like them publish their rates, and those prices are higher than Surgery Center, people may say, I don't want to go to Surgery Center anymore. I want to go to the high-price hospital. Why? Because people automatically assume that if something costs more, there must be a reason. And that reason is it's better. And that's why I believe so many people are quick to grab the brand name drug off the shelf instead of the store brand. It must cost more because it must be better. So I am worried that if we focus entirely on price transparency and don't look at other forms of transparency like quality, outcomes, never events, technology, efficiency, effectiveness, access, timing, complications, you name it, right? Malpractice. If that information is not transparent as well, and the only thing you're making a decision based upon is the price, particularly if insurance is picking up most of the bill, who's going to go to the cut rate provider? If you could pick between, and I got nothing against it, but a Toyota Corolla, right, or a Ferrari, you look at the price and say, I want the Ferrari. Now, if I told you that you could have two Corollas, one is half the price of the other, but there's zero difference between them, and by the way, you can keep 1% of the difference in the price, now you go for the cheaper option. So the point is people need to, A, have an incentive, and B, information above and beyond just the price. So I think it's important that we keep that in mind as we proceed as well. John?
Thanks, Ron. As of 1/1/19, the new CMS rule, which we mentioned briefly in last month's webinar, it requires hospitals to publicly post charges online in a machine-readable format on an annual basis. All of those are kind of buzzwords. I was looking through the FAQs that were published, and every time I read the FAQ, or the question rather, I said, oh, here we go, here come the exceptions. I was actually very much pleasantly surprised with what the FAQ said. In particular, one of the questions, and I apologize, I don't remember the exact form of the question, but it basically said, to which hospitals is this rule applicable? And I said, oh, here we go. Here, let's list all the exemptions. There are none. There are no exemptions. It's all hospitals. And, that's fantastic, because in the past there have been a lot of things that apply to only certain hospitals, and, there are exemptions and exceptions up the wazoo, but here it's every hospital. And that's, this has the potential to be really great for our industry. And on this next slide, I've got some quotes, and I'm not going to spend the time reading them, but it's important to note that it seems like CMS is really concerned with the cost to the patient. It doesn't seem like they're focusing much on the cost of the health plan. In reality, as everybody dialed into this webinar knows, and as Ron just explained, the cost to the patient, I don't want to say it's irrelevant. It is certainly not irrelevant, but it's capped. It's capped at the out-of-pocket limit, whereas the cost to the health plan is potentially astronomical. So when we're looking at transparency and we're looking for rules to promote transparency, I think that one of the focuses has to be who's actually paying the claim, right? The member is paying the member's portion, and then what happens to the rest? Well, nobody seems to care. We all care. Everybody dialed into this webinar cares.
John, you know what drives me nuts about that? If you said that you refuse to spend more than $5 on a sandwich, and I tell you, okay, John, give me $10, and then I'll buy the sandwich for you, and you're like, okay, as long as I'm not buying it.
Right.
That's what you're seeing here. The money's coming from somewhere. So again, you're just passing the buck, but ultimately it's still coming out of the pockets of the insureds.
Real quick on hospital listening, we did a podcast, Ron, myself, and Philip from our office, worth listening to. It goes into detail about some of the shortcomings of that CMS rule that John mentioned. Really quick here on PPO transparency. I can answer the top two questions with the word yes. Your PPO does hide provider networks from you, most likely. Yes, the contract is probably so proprietary that you can't share it. Briefly, an upside-down DRG, this is an interesting case here, where basically you've got a network agreement which sets forth a certain flat price for a claim billed as a DRG. That's regardless of the billed amount. We've seen cases where people come to us and say, the billed amount was so low, the DRG amount was so high. Help us, stop loss is not reimbursing the DRG amount. Happens all the time. It's buried in your PPO contract. No transparency. Do you have a right to audit your claims? Probably not, but even if you do, what kind of audit? We've had tons of problems, or we've seen tons of problems with clients who come to us saying, oh, we only are allowed a targeted audit or a generic audit. What kind of audit? Who's paying for it? So even if you answer yes there's probably still a problem. And yes, there also probably is a separate secretive provider agreement that you can't see as well. That sounds very negative and disheartening, but they're all true. Again, audit rights to the stop loss policy. Who has them? Who's paying for them? What's the scope of the audit? How is UNC defined? These are all questions you have to keep asking yourself as you're trying to, figure out if you're going to have stop loss reimbursement available to you. Look out for mysterious claim submission processes. So, is there a certain deadline that you may have missed? What does proof of loss mean? What does it entail? We are experts in reviewing these provisions and telling you what these provisions mean. So come to us with those questions. And the issue of rebates, again, are they the plan's refunds? Even when the plan doesn't get to keep them, does the PBM get to keep them? And if so, does that impact stop loss reimbursement? Spoiler alert, yes, it does. And we can also help with those problems and inquiries as well. Ron, over to you for the last slide.
All right, so we're going to leave you today with some homework, okay? First, you're going to make sure that your plan language is clear, right? One, you can actually explain how the pricing occurs, no black box. But on the other hand, your plan document supports that process as well. You're going to seek out transparency, not just in pricing, but in general, whether it's contracts. Look for providers that are not only willing to share what they'll accept, but other quality metrics. Educate your staff, your plan participants, what those quality metrics mean. Tell them, hey, look, I'm not asking you to go to the cheaper facility. I'm asking you to go to the better facility, both on price and quality. And make sure you're going through every document, every contract, every policy to identify potential issues, vague items, ambiguities, gaps, places where things are not necessarily explained, because the last place you want to end up dealing with some sort of gap in coverage due to an ambiguity or lack of transparency is when the claim is already in hand and it's too late to renegotiate. So with those stages in mind, if you feel like that homework is too difficult for you, you can give us a call. I know John is used to helping people with their homework or helping them to defraud their ways into college admissions or something like that.
Oh.
Anyway, moving on.
What does that even mean?
I'm just kidding. I know about all the hot media. So anyway, on behalf of myself, John, Jen, Brady, and the entire Phia Group family, we thank you for joining us for this month's webinar. We look forward to you joining us next month as well. Thank you once again, and thank you for allowing us to empower your plans. Have a good day.